Well, Brian Hoelzer and Eric Freeman were kind enough to present this morning on sacroiliac joint pathology and treatment options, and even compared the sacroiliac joint to a particular hairstyle, which was amazing. So
hair's very important.
Yeah, so tell us a little bit about things that patients should know about the sacroiliac joint and what symptoms they have when they have sacroiliac joint problems.
I think one part of it is that the sacroiliac joint is an incredibly common source of pain.
Mm-hmm.
I mean, it's prevalent, men, women, all ages, young, old, and typically how you're going to feel it is you'll start having pain in your low back, pain in your buttock, it'll go down into the thigh, and it tends to get worse with certain transition movements as you're standing from a seated position. And it can be treated quite well with conservative therapies, and really can be able to get it under control so you can get back to living your life without too much disruption.
Yeah. One thing that is interesting to me is 10 years ago, SI joint wasn't as commonly thought about in clinical medicine. And one of the reasons is you don't see it on an MRI very easily. You can see a disc herniation, you can see an annular tear, you can see spinal stenosis, but you don't really see SI joint. And so what I loved about the discussion in part was that we all have ways of making this diagnosis within the community. Your chiropractor can help, your physical therapist can help, you guys can help. We're not that helpful in the diagnosis, but we're still here. But I think that that's such a good example of where we can all help make that diagnosis. Is that kind of what you've seen in the community?
Yeah, for sure. And it's interesting you bring up that 10 years ago people weren't diagnosing it as much. And there's probably a number of reasons. One, you don't see the imaging stuff that you just talked about. Two, it's really, really hard to diagnose. It takes a really focused physical exam. It's understanding anatomy. Sometimes it even requires those injections, so it's hard to diagnose. And then I do think we're seeing an increase in the diagnosis now, maybe because people are more aware of it, but also if you look back through some of the spine literature, fusions became much more common in the 90s and the end of the 90s. And we know that once a patient's fused, that SI joint is going to take on more stress. And I think we're starting to see some of those patients that did really, really well for 20 years, and now their SI is painful to them. And so I think that's also a reason why maybe it's ticked up just a little bit, for sure. So I think it takes a team to really understand it and diagnose it.
Yeah. All right, so we've made the diagnosis, and I think that one of the great things about doing this conversation is just that awareness, because I think sometimes patients can help us with that diagnosis, knowing what the symptoms are, coming to a provider, do I have SI joint pain? Let's talk a little bit about what treatment options are available for patients currently.
If we look at treatment options for SI joint pain, there's a really wide spectrum. And a lot of times, like we mentioned, using physical therapy techniques as far as strengthening and stabilizing the joint, or chiropractic techniques, can often get it under really good control without having to require any type of medication or injection. And so they'll be able to strengthen those muscles and stabilize the joint. If for whatever reason that doesn't help to calm down some of that pain, and it still limits the activities and limits what they're able to do, or there's a question of, is it really the joint or is it something nearby? That's where we'll often use different types of injections into the joint itself. That will, one, give us the diagnosis that yes, this is the right cause of the pain, we've identified it, and if we inject a small amount of either steroid into that joint, that can be able to relieve inflammation and help with the pain as well.
Mm-hmm. I like that, yeah. I think that oftentimes the patients can get great relief with chiropractic and physical therapy, especially as they expand the view, like, why are you having sacroiliac joint in the first place? Is it a leg length discrepancy? Is it a stiff ankle joint? And there's some work in it, and it's creating a biomechanical stressor. So let's fast forward a little bit further. This patient's made an accurate diagnosis. We've had them do work with chiropractic or physical therapy. 3 injections have been done, all of which give temporary relief, but then the pain comes right back. What do we do next?
So I think that's the real, where there's quite an explosion of trying to understand the right next thing to do for those patients. Often, for a lot of years, there wasn't a lot to do for them. There's been advancements in the last 20 years with various ways of stabilizing or fusing or distracting the joint, particularly the lateral approach that's been used for a long time. And now there's even some talk and understanding of using less invasive posterior approaches to stabilizing that joint. It's still, I think, in the infancy of these treatments. We're starting to understand them better, but we don't understand enough. So there's a lot more data that needs to come out to help us understand which patient would do best from which approach. But if a patient has gone through all the conservative treatment and through sort of the simple injections, which we should reiterate, the vast majority of patients do just great with those treatments. But for that small set of patients that don't, then some of these spine stabilizations or fusion procedures that are meant to be minimally invasive with a quick recovery do hold a lot of promise for these patients.
And then the final question would be like, how can we as clinicians help patients navigate some of these options? Because you're right, there's been an explosion. I can't keep up with all of the different things on the market now and the different approaches. And how could a patient keep up with that? And how can we help patients know what's right for them?
For me, I think it really comes down to an honest conversation with them. Here's what the data is that we have so far. Here are the approaches, and just simplifying because all of them have a little bit of an advantage and maybe a little bit of a disadvantage. And then I also think getting a second opinion. So say, for example, you, Dr. Edwards, primarily approach it with a lateral approach, which is an excellent approach and a very good data for that approach. Making sure they understand there might be a different approach and having them see a different clinician that might be doing inferior posterior approach or a posterior approach, so that way they can have a discussion with a couple of clinicians that could give them the pluses and minuses and look at their CT scans and look at their imaging and understand it, might be a helpful way of helping those patients understand it.
I think that I agree with it. I think a lot of times in medicine we have this tendency to think that we're supposed to have all the answers ourselves. And like you mentioned, in this particular topic, it's very difficult to stay up to date on it all. And so relying on the colleagues in our community, surgeons, physical therapists, others that may have additional information that we don't have, I think it's really important to be able to reach out to those people and tell our patients that, and be honest with them of this is what I do, this is what I understand. There may be a better option. I'm going to send you to someone to have that conversation because we just want you to have the best outcomes possible.
And I think over time our community has gotten better and better at embracing that. We're not worried about, oh no, if this patient goes off to you guys and has a different approach, I'm losing business or something. Like, I don't think there's a feeling of that. And I think if there's a better option for somebody, that's what we would want to see. If there's a better way for a patient to get a better outcome, then and we want to see that. And so I like that we have these ongoing conversations and have really embraced, I think, that our number one priority here is to see the patients get the best evaluation and treatment as we can provide as a community.
Absolutely, yeah.
All right, well, thanks so much for coming.
Thank you.
Appreciate having you.